Hello to all the audience members in Cape Town who are attending the World Congress on Pediatric Cardiology and Cardiac Surgery. It is an honor for me to be with you today and participate by video, and I regret really not to be physically in person with you. And I thank Dr. Lee Zulke for inviting me to contribute to this conference. I want to talk about my country, Rwanda, and to talk about the principles that are leading the healthcare service delivery. The major principle is equity in access. We don't have enough for all, but what we have, we share it in an equitable manner. And this principle, we have built on it because of our history. Before 1994, before the genocide against Tutsi, we had a system based on inequity. Some of the Rwandans cannot have access to care, to education, or other benefit just because of their ethnic, or because of their family, or for what they stand for. Now, we change it. And we have a system based on geographic equity, we have a system based on gender equity and age equity. And this has changed all the situation in the health sector. For infectious disease, we have reduced the death during the last decades for HIV, TB, and malaria by more than 75%. Rwanda is on track for MDG 4 and 5, and life expectancy came from 28 to now 60 years for life expectancy. Based on this, we really want to tackle non-communicable diseases or some diseases that are categorized non-communicable but are based on the ground of an infectious disease, like some cardiopathy. One of the major problems is that for cardiac disease, especially for children, advocacy is very difficult. Africa is still seen as a country where we should talk about infectious disease, about vaccination, family planning, and those diseases are totally neglected. One of the reasons is because we don't know the epidemiology of those diseases, so we don't have evidence for advocacy. But whatever, we have validated estimation for the region, and we can base our strategies, our policies, and our advocacy on that. We have policies and strategies. We advocate, but there is no response at global level. An example, we know that non-ischemic heart disease, especially rheumatic heart disease, cardiomyopathy, and tubercular pericarditis are the major cardiac killers in Africa. Rheumatic heart disease affects more than 2.4 million children around the world and causes mortality that is similar than rotavirus. And for rotavirus, there is a global movement. There is a support for vaccine, a support for teaching families at community level what to do to avoid it. For cardiac disease, there is almost nothing. Another example, rheumatic heart disease causes mortality that is half that caused the one caused by malaria. And for malaria, there is this global movement from head of states, from Bill Gates to the community level. For heart disease, there is still almost nothing. And to give you data, you should know that rheumatic heart disease receives less than 0.1% of the global health funding, when it kills as much as the rotavirus and as much as half of the malaria. So this have to make us think about what to do. But still, the voice, when we talk about it, is like screaming in the desert. So, we should acknowledge that it's a highly neglected health issue. And as a pediatrician, I know that pediatric patients are disproportionately ignored, especially in our country, in developing countries. This is because children are voiceless. They cannot stand for themselves. They cannot go in YouTube and send a message on their condition and scream for and ask for treatment and support. We need to be the voice of those children. We need to assure that this message passes through this wall that make the world blind about the rheumatic heart disease. We should ask ourselves why this disease is ignored by global health. At the time, global health started to have the right position in the framework of access to care. Global health is not only about immunization, it's not only about HIV, TB. It's about looking as an individual as it is. An individual who is at risk of HIV, of TB and malaria. Those are the same people. Those are the same children. And we cannot save them from HIV. We cannot save them from gastroenteritis due to rotavirus. We cannot save them from malaria and let them die because of rheumatic heart disease. This is a nonsense. This is an economical nonsense in matter of development. And what we know, we have made great progress for HIV. At the time, global health was not what it is today. At the time, people were saying, in the developing world, IRVs are not something to give to HIV positive people in Africa, in India, and other parts of the world, because those people are illiterate. They will misuse the drugs and bring resistance. And what happened? In our part of the world, the response to the disease is far better than in the north. The rate of survival, the rate of viral load suppression is far better in Rwanda than in America. And I'm sure that if we manage to bring treatment to the children affected by rheumatic heart disease, the result will be as good as in your country. But we should not forget prevention. Early access to treatment when you have streptococcal infection in the throat. We should bring those treatment at community level where the children are living so they don't have to go far to get treatment. We should train people, doctors and nurses, in cardiac surgery. And we should avail good post-surgery care and follow-up. This is something we can do together. And this is something I am sure will have good results in Africa. In conclusion, I would like to say that we should not give up. The history of global health have shown that this will pay fruits and gain life. And this is the right fight for the world now. This is the next frontier. And don't forget, this is a cross-cutting issue between infectious disease and non-communicable disease. And we know that if we bring the capacity to implement screening program for congenital disease and prevent infectious disease that are at the roots of cardiac disease, we will have a comprehensive approach for children at risk of heart disease. So Altogether, we have to advocate for pediatric heart disease to be part of the post-2015 development agenda. It has to be part of the next MDGs agenda, to receive proper funding, and to be recognized as a major killer, as it is for our children in Africa and elsewhere. We need to advocate to have proper data so that we have evidence on what to do and where to do it. And as we have done in the past decade for infectious disease, we will succeed to make it. This needs new researchers, and this needs access to drugs, and this needs a huge development of human resource. So this conference is really an important conference because it's the start of that. And be sure that we in Rwanda, we are with you in this fight, and you can count on us to join our voice to your voice for better care and better health for our children. Thank you. I want to dedicate the words I have exchanged with you to a teenager, a young girl, beautiful adolescent, that I had the chance to send to France in Belgium to be operated, cardiac surgery, in 1997. At the time Rwanda was destroyed, it was after the genocide. But she got the chance to survive and to grow in a beautiful adolescent just because she had the chance to have timely heart surgery. Every child in the world should have that chance.